So as I said, the trial of Gleevec versus interferon and cytarabine was terminated early because it was clear that Gleevec was so much better, both in terms of tolerance but also in terms of response. And so most of this, so this is this trial, this IRIS trial, but what happened was that pretty much everybody who got started on the interferon and RSE ended up back over on Gleevec because it was clear it was better. But they've then continued to follow the group that just initially got Gleevec out for many years. And so this is really just the group who initially got Gleevec on that very first sort of trial, and showing that in those people, about 6% at 7 years had died of their disease from CML. So there are a few more that have died of other reasons, been run over by a bus or eaten by a great white or something like that. But the very sort of relatively small numbers of patients who had died from their disease. Before we go any further, it's sort of this is where I guess a talk on CML gets tricky, in that we use a lot of different definitions of response. And so the idea is that we can detect disease in the blood and the bone marrow, but then we use different thresholds to say, oh, you've made it down this far, and then you've made it a bit further, and then you've made it a bit further. And so complete hematological response is where your blood film now looks normal and your blood counts look normal, and that often happens fairly early on in the course of treatment. A major cytogenetic response we often don't even assess anymore. That was sort of back when we used to do regular bone marrows, which not many of us do too much anymore. And so that's that was when you had less than 35% of the Philadelphia cells in your bone marrow. Complete cytogenetic response is where you don't have any of the Philadelphia cells in your bone marrow. So you're sort of getting down to lower and lower levels of of detectable disease. A major molecular remission is where the percentage of sort of abnormal cells, if you like, in your blood is only 0.1% or less. And so that's a fairly major endpoint. And the reason why it's a fairly major endpoint is that it does seem to be a level, if you get below that, then your chances of progression are pretty small. So there's really only been a handful or a couple of handfuls of patients around the world who've sort of progressed from that level, providing they continue to tolerate the medicine. And so and because of that, that's also now been an end point in a lot of trials. And so the trials are actually determining, when they compare one drug to another, they determine how many people get into that major molecular response. And then there is another level below that, which is a complete molecular response. And this is where it gets a bit murky, because really complete molecular response means we can't detect the disease at all, but that depends on how good your test is. And so there are lots of different ways of testing this. There's the standard PCR test, which most of us use in general practice, but there are more and more research-oriented methods to detect down to lower levels. And so really, complete molecular response just means you've responded down to a level below which we can detect you, but that depends on how good our test is. And to try and get around that, they've sort of created these other levels, which are a level of response of sort of 4, which is 0.01%, and 0.45, which is 0.0032%. And so I'll talk about this one later, because this MR 4.5, or molecular response 4.5, stands for 4.5 logs below diagnosis. So each log is reduced by a tenth. So it's down to a tenth, down to a tenth, down to a tenth, 4.5 times, and that's sort of been a definition which we're then using to now say that you're in complete molecular response, even though we might be able to detect you at 0.0031%. We're saying you're in complete molecular remission because that's just a standard that we're sort of trying to use so that we sort of know what we're doing, rather than have to compare my test to somebody else's test. All right, and so the importance of that is that as you then look at the people from this IRIS trial, so these are the people who were initially treated with Gleevec, the longer you stay on the drug, the deeper your response seems to be. And so the people in yellow here have achieved that major molecular response. So you can see that if you only look at 12 months, only on Gleevec, on this trial, only about half of the people will have achieved a major molecular response. Whereas if you look out here at sort of whatever that is, 6 years, then you're getting sort of 90% or so who will have achieved a major molecular response. So some people take a long time to get there, but the longer you stay on the drug, the better your response tends to be. And similarly, if you look at the next level down, which would be, we'd now call an MR4, you know, again, more and more people over time achieving that level of response. And what that means is that most of the people who progress on these drugs do it in the first year or two or three, you know, probably a year or two. And as you get along, there's less and less people progressing because people are in deeper and deeper remissions, and we know that the deeper your remission is, the less chance you've got of progressing. And so, you know, this is the... Sorry? Is that a foregone conclusion? If you're right down there where you're not going to progress? Can you progress at later stages? It doesn't seem to be. So this, you know, this is a blip, but it seems that this is getting, you know, the risk of progression is lower and lower as the years go on. And yes, as I said before, you know, if you're in MMR, it's not totally safe, but the chance of progressing from MMR is very small. So the other importance of worrying about where you get to, as I said before, the deeper you go, the less likely you are to progress, but also it's time dependent. And so if you do get a deeper level earlier, then it just gets you into a safer zone earlier, if you like. And so this is just one example, and I could throw you, there's hundreds and hundreds of these graphs, but if we look at people, and it doesn't matter what they did up until 12 months, so they've just taken people who are on this trial at 12 months on Gleevec, then if you did achieve this major molecular remission, this is your chance of not progressing, if you like. So, you know, your chance of not progressing if you're in major molecular remission on this trial was about, what, 98, 99% or something like that. Whereas if you didn't achieve this complete cytogenetic remission by 12 months, then this is your chance of progressing. So still, you know, more than 70% of people haven't progressed, but they've got a higher chance of progressing. And so that's why we have certain thresholds that we like to meet to sort of see that, you know, patients are sort of travelling and getting into the safest zone possible. And really then this is an attempt to put this in a table. And so this is the European LeukaemiaNet, where they've just basically created a table of what they consider, based on the current evidence, is, you know, optimal outcomes. So getting less than these certain levels of BCR-ABL at these time points versus outcomes where you're a bit worried. You know, may not mean that you change anything, but you're a bit worried and want to watch a bit more closely. And then levels that they would consider a failure, where we may be having to think about doing something different. The difficulty with this, and even this, is that at the moment we don't have a lot of data about what that something different is. And so we can tell you that we're a bit worried, or we think that this isn't working fantastically, but we can't really necessarily tell you that you're going to do better with anything else.
Would you go back to a bone marrow in that case?
Perhaps. So certainly we do have people who fail these levels, and then, you know, we might try a second drug, and then if they look like they're similarly failing the second drug, then they go on to bone marrow. So, you know, bone marrow is still being done for CML, but you have to be usually pretty young. So a bone marrow transplant's generally only considered if you're less than about sort of 65, sometimes 70 at a stretch. And has to be a really sort of good reason to do it these days, which is usually having failed at least 2 drugs, so sometimes considered still. So getting back then to the fact that there are now multiple drugs other than Gleevec. So this is the BCR-ABL protein that I was showing before sideways. This is now looking at it front on, so it's like a little Pac-Man, you know, looking front on. So this is Gleevec sitting in the little groove of the protein, and this just shows you that the different drugs have just been designed to sit in that groove slightly differently. And the importance of that is that the way that a number of patients who sort of where Gleevec doesn't work, it may not work because they have mutations within this protein which changes the structure of the protein a bit, where the Gleevec can't get into the groove, if you like. And then these newer drugs, Nilotinib and Dasatinib, also have some mutations that occur in that protein where they can't get into the groove as well. And so if things aren't going as we plan, then we do try and look for these mutations to see if if we can identify the reason why that particular drug's not working, and it may be that it's not getting into where it's needed. And you can see that there are certain mutations that that are resistant to Nilotinib, and there's certain mutations that are resistant to Dasatinib. And so if we find one of these mutations, it may help choosing which drug to go to next in some patients. There's also one mutation that's basically resistant to all three of the currently licensed drugs. That there is another drug which is being used sort of in trials largely around the world for that other mutation. It's quite a complicated test, but it is available in different centres around Australia. It's generally only considered if we think that patients aren't responding to the treatment. It's not necessarily because if we look at it in everybody at the start, it's never there. So they're mutations which are sort of selected out as you go along on treatment, rather than mutations that were sort of there at the start when the disease was initially discovered. Really, this is just to show you that potentially because they've got less mutations, there do appear to be slightly deeper responses to some of the newer drugs, so Nilotinib and Dasatinib, but I'll tell you why that's not necessarily why we haven't just switched everybody onto the newer drugs in a second. So this is the trial looking at the people who are on Nilotinib versus Imatinib, and the blue bars are Nilotinib, so more of them had achieved a major molecular remission on Nilotinib than Gleevec. Similarly, this is the trial looking at Dasatinib Gleevec. So again, more people had achieved a major molecular remission on Dasatinib than Gleevec. And on the trial of Nilotinib, there did appear to be less people that progressed during the initial sort of, as I said, year or so of treatment on the Nilotinib arm, less people progressing compared to the Imatinib arm. And so it does seem that the newer drugs might be better at getting you down quickly to a lower level, and therefore, hopefully protecting you against progression. The downside of that is that there are a couple of sort of significant side effects that we worry may be occurring with some of the newer drugs. So this is the side effects that you expect from this is again the comparison of Nilotinib versus Gleevec, and the important thing is that you get more nausea, muscle spasms, muscle aches, diarrhea and vomiting with Gleevec, but more rash, headaches, itchiness and hair loss with Nilotinib. So that they've got particular side effects that we can look out for. You get more in the way of swelling with Gleevec, so more in the way of swelling in your legs or swelling in your face with Gleevec compared to the new drugs. And then this is the data looking at then Dasatinib. So this is the other one rather than Nilotinib. And you can see that again, the orange bars are Gleevec, so more of this swelling, more muscle aches with Gleevec, more nausea with Gleevec. But Dasatinib's got a particular side effect that we watch out for, which is where it causes a pleural effusion, which is fluid outside your lungs, sort of inside your chest, but outside your lungs. And so that can be problematic if it happens. We need to sort of obviously manage that if it happens, which can often be managed very successfully, but it's one that we watch out for on that particular drug. And so really then, because of that, as I said, it's not a straightforward decision as to which drug you should go on. There are some that appear to be a little bit better at getting the levels down quickly, but they may have other specific side effects that your doctor's particularly worried about that lead them to choose one drug over another.